Good evening and welcome to League of Women Voters Presents. I'm Jim Robertson and my guest tonight is Karen Edison. She's chair of the dermatology program at the MU Medical School.
That's correct.
And do I have this right? A former fellow at the Robert Wood Johnson Foundation in Public Health Policy?
That's right, Jim. Back in the 1990s, late 1990s, I went to Washington and served in the United States Senate as a Robert Wood Johnson Health Policy Fellow. And that was a lot of fun. I came back to Missouri in 2001, and in 2002, together with Dr. Christopher Haglund, started the Center for Health Policy here at the university. And since that time, we've been working hard to do whatever we can to improve health and healthcare for all Missourians.
Well, so you're really steeped in our topic tonight, which is Medicaid expansion. Today, the new session of the General Assembly started in Jefferson City, and one of their big topics of debate, and it promises to be a pretty contentious topic, is expansion of Medicaid. It's part of the Obamacare.
Right, so the Affordable Care Act or the health reform package, what some people call Obamacare, did many things. One of the things it did was try to expand access to health insurance coverage. It did this in two primary ways. One way was this Medicaid expansion we're talking about. The other way was through what are called health insurance exchanges that we can talk about a little bit later. Medicaid in Missouri is called MoHealthNet, and I think it's important to point that out because it confuses people sometimes. But so Missouri's Medicaid program is called MoHealthNet or Missouri HealthNet. And that program is a $8.2 billion program this year. It's a big program. It covers roughly 1 in 7 Missourians. And if we expand our Medicaid program in accordance with health reform, it would cover maybe 1 in 5 Missourians eventually someday. Right now, we don't cover many adults if they don't have children in particular. We also only cover adults with children if they're extremely poor. In fact, making less than 19% of the federal poverty level. So,
and how much, for example, and you might not know the answer to this, but what are we talking about in income and a family at that level?
So right now, the federal poverty level is about $14,000 for an individual, just several $100s a month in income, really. So it's a very low income level, and we really don't cover very many people that are working and are low income. And so the Medicaid expansion calls for covering everybody up to 138% of the federal poverty level. So whether you're a parent, whether you're a single adult, whether you're a disabled person, up to 138% of the federal poverty level. So that would really expand Medicaid coverage for the lowest income folks in the state.
And how many Missourians are we talking about fall under that guideline?
So there have been 3 or 4 excellent reports trying to project what might actually happen in Missouri if we decided to expand our Medicaid program. Most of those reports come in somewhere around 200,000, maybe 250,000 Missourians would gain coverage if we expanded our Medicaid program. You know, one of the things you'll hear a lot is how much the federal government is willing to pay. And for some people that's a good thing, and for some people that's not such a good thing. But the way it's designed right now, the federal government would pay 100% of those costs starting next year in 2014 and for the first 3 years. And then in 2017, the state would have to kick in about 5%. And this would expand to 10% getting up to 2021. So it's a much lower contribution from the state than it is from the federal government. And so it would bring a lot of money to the state in new jobs and economic vitality. And so there are lots of folks who want to go ahead with that expansion.
You've worked on both ends of that equation, the federal government at the federal level and the state level. What do you say to people who say we can't afford that?
Well, that's a very valid concern. Medicaid is a huge program in the state. I already told you it's over $8 billion, and It's one of those programs that pushes on other priorities like education, higher education, K through 12 education. It pushes on other things we'd like to do in state government. And so it is a big program, and that is a valid concern because there would be costs to the state. And so many of the people opposing it are concerned about that cost. They think Medicaid already costs too much. They're also concerned about expanding the role of the federal government in what they call social welfare programs. So it really is kind of a philosophical or an ideological question about the role of government in health care.
Isn't it true, though, that at the present, healthcare costs take, 17% of the economy?
Right, nearly 18%, right?
Much more than other developed countries.
Nearly twice as much as other developed countries.
How will the Affordable Care Act and healthcare reform trend those costs down?
Right, so the Affordable Care Act is seen by most folks in health policy as just the first step. Just a big piece of legislation that did a lot of things but didn't do it all. Anything that is 17–18% of the whole federal economy, you can't do with one piece of legislation or one fell swoop. So it's going to take many years. There are going to be lots of unintended consequences. We're going to have to, tinker with it and change it as we go. And that was fully expected at the beginning when people were talking about health reform. The Affordable Care Act, Obamacare, really just started to tinker around the edges of cost controls. Everybody knows healthcare is too costly. And in fact, we just heard recently that healthcare costs increased 3.9% in this last year. And that's the same amount it increased in the 2 years prior. And that's really a big deal because in the decades prior, we had much higher increases in health spending, sometimes even in the double digits.
Right.
And so for health spending to be held at 3.9% increase for the last 3 years really tells me something. And it tells me that folks in healthcare and folks in the public are beginning to understand that our healthcare system is just too expensive. We can't really afford everything for everybody at the highest cost. And we're going to have to work together to get those costs down. We're going to have to involve the public and our patients in understanding that sometimes the most expensive test isn't really indicated or isn't the best choice. The Gallup Institute did a poll recently, or in this past year, and they interviewed physicians nationwide, did a big poll, and physicians said that defensive medicine costs up to 26% of healthcare costs.
My goodness.
Now, it may not be that high, but even if it's half of that, defensive medicine really costs a lot of money. And defensive medicine is ordering a test when you pretty much know there's no indication for it, but you want to make sure that, you just don't miss that one thing,
right.
So like ordering a MRI for a bad headache or something like that, that's defensive medicine. And
right.
There's probably quite a bit of that going on. And really health reform didn't do anything around medical liability or rationalizing our...
So that might be another piece of reform down the road.
Exactly.
When you talk about Medicaid expansion, those uninsured are getting some health care now at the crisis stage, let's say, at the emergent stage of their illness or injury. And that is, somebody's paying for that.
Right, so uninsured, we eventually pay for the uninsured, but if you don't have health insurance, you're much less likely to go to the hospital, even the emergency room. And yes, there is a federal law that requires us to stabilize patients and evaluate them when they come to the emergency room, but that's not a place to get your primary care. That's not a place to get your preventive care. So people wait until it's late, until they have very severe diseases and they end up costing us more money. So it's really a bad way to think about controlling healthcare costs, limiting care to people by denying them insurance or denying them access to healthcare. We know that we need to give better access to healthcare. Healthcare needs to change, Jim, and it's an exciting time to be in healthcare. You know, I see the future looking very different. You know, we're going to use technology to connect to our patients. I always say healthcare yesterday was centered around the hospital. Today it's around the clinic and the outpatient environment. And tomorrow it's going to be about wherever that patient is, in their home, on their cell phone. Healthcare needs to go to patients if we're really going to be patient-centered in the way we care for folks.
So that will, rural healthcare has always been a problem to get physicians and health professionals out into the rural areas. So that could be a revolution in rural healthcare.
Absolutely. You know, I've been doing telemedicine personally since 1994, I think, in rural areas all over Missouri, once a week, except for the 2 years I was in Washington, D.C. And I can tell you that every time we go to a new small town in Missouri and start seeing patients there, we always uncover pockets of patients who have very advanced healthcare conditions who haven't been seen. And, you know, if you can get a healthcare provider to use telehealth and they see a couple of these patients, many times they become champions of using the technology.
Sure. Okay, let's go back. I want to steer you back to Medicaid expansion here for a minute. We talked a little earlier about the impact on rural hospitals and rural healthcare if the state does not expand the Medicare. Can you talk a little bit about that?
So it's a real concern. It's a concern for small hospitals. It's also a concern for middle-sized hospitals. Hospitals are under a lot of pressure right now. Like other healthcare providers, hospitals have their share. You know, in the negotiations for Obamacare, for the Affordable Care Act, hospitals agreed to bake in some cost reductions in the out years as years go on, and they agreed to those reductions in reimbursements because they understood that Medicaid would expand and that the health insurance exchanges would come into effect with tax subsidies and tax credits, and so that more people would have health insurance. So the hospitals said, okay, if you're going to have these programs that will expand coverage for the uninsured, we'll agree to some cuts in our payments. Hospitals that care for the safety net for folks who don't have health insurance are at even higher risk in some ways because there's a whole nother funding stream of money that comes in for uncompensated care for people who don't have health insurance, and those dollars are going away. So in the rural areas, if you're a small or a medium-sized hospital, you're already dealing with a lot of federal programs, like getting to electronic health records and meeting a lot of other requirements. You know, if they reduce the reimbursements and at the same time don't expand Medicaid, that's going to be it's going to really put hospitals in a pinch. And we're worried because in many small towns in Missouri, the hospital in many areas is one of the primary employers. It's really the center of commerce in many ways for that small town. You know, that's why I like doing telemedicine, because when I prescribe a medicine, they fill it in the local pharmacy. When I order a lab or an x-ray, they get it in the local little hospital. It's really an economic driver for that small community. And I think people in Washington, I spent 2 years there, and they're good people working really hard trying to solve problems, but they really don't understand rural health care. I was in a meeting on rural health care in Washington one time for an hour and a half, sitting around a table with 40 people. And it took me about a half an hour to realize I was the only person at the table who'd ever delivered health care in a rural environment. You know, and they really don't get it. They really think that if you have roads and you have cars, people will drive for their health care. I learned that lesson years ago when I started doing a little outreach clinic up in Moberly, you know, 35 miles north of Columbia, and learned very fast that there are people who just will not leave their home communities for their health care for a variety of reasons. It's a lot of different things. You know, people would look at me and they'd say, I'm 80 years old, my friends are dead, my kids live 200 miles away, hurts my back to ride in a car more than 15 minutes.
Yeah, it's a huge ordeal just to get that 35 miles.
Yes.
So you have to take the medicine to them.
Yes, we have to take health care to people where they are, and we have to do it when they need it, and we have to take the right expertise to them when they need it.
So you're telling me that the hospitals, the rural health systems have already taken their medicine. They've agreed to take the cuts, thinking that the Medicaid expansion would cover that loss. And now along comes the state of Missouri saying, well, we're not sure we want to do the Medicaid expansion.
Right. So as you might imagine, the Missouri Hospital Association and many others in healthcare are fairly alarmed that we would not expand our MoHealthNet program, understanding why people would have concerns about it, particularly who have responsibilities for the state budget. Now, the governor's Office of Budget and Planning came out with a projection that showed it would actually save us $250 million over 3 years, particularly around the areas of women's health and mental health. And you might say, well, how is that possible? Well, with women's health, turns out in many areas, less than 70% of newly pregnant women go to the doctor in the first trimester. And so if you expand coverage for people and they can go to the doctor in their first trimester, pregnancies go better, and you have fewer low birth weight babies and fewer infant mortality events. And so, you know, really better earlier care for young pregnant women is really a cost saver in the long run. The other cost saver is in mental health, because there are state programs around mental health that are fully state funded. And if some of those patients then become eligible for Medicaid, then a lot of that care will be able to pull down a federal match for that care.
I see.
So Linda Lubring and all the good people in the budget office down at the state really took a look at that and said, no, we might actually have $250 million in savings over these 3 years. So I think the fact is nobody really knows how it will all play out, but the promise of 100% federal funding and expansion for up to 250,000 more people, which is, you know, 25–30% of our uninsured population, it's a pretty attractive proposal for most people looking at it, I would say.
So I guess any opposition would be based on ideology.
Well, not just ideology. I would say ideology for sure. Certainly there are people in our state assembly who just have a philosophical problem with expanding the role of government, particularly in healthcare, particularly for the low-income population. But there are also, you know, very valid concerns about where the money's going to come from when we have to start paying part of that cost. So I think both of those things are at play here.
The Medicaid expansion is, because of the Supreme Court ruling last spring, is an opt-in kind of
Right,
situation.
we should talk about that. So the Supreme Court last summer, you know, everybody was looking at the issue of the individual mandate, and they upheld the individual mandate. They said it's actually a tax, but they upheld it in the law. But what we didn't expect, what people in health policy didn't expect, was that they said states don't really have to expand their Medicaid programs. You know, in the law it said if you didn't expand your Medicaid program, then you'd lose federal funding for your regular Medicaid program. And
pretty big stick.
Pretty big stick. And the Supreme Court said, no, that's a little too coercive on the federal government's part. And so the states can choose whether to expand their Medicaid programs. So that was a little bit of a surprise, and states all over the nation are struggling with this question. You know, it's not clear, and you can imagine, think of it, you know, Missouri borders 8 different states. You know, what if those 8 states expand their Medicaid program? You know, you can see, you know, what if someone lives on the border? You know,
and Illinois is going to expand their Medicaid, no doubt about it. Kansas probably won't. So yeah,
so
it's
an
interesting,
interesting
dynamic. The other opt-in feature of the Affordable Care Act was the health exchange, health insurance exchanges. What exactly is going to be the difference between the federal government running that exchange and the state government?
I'm glad you didn't ask me exactly what Missouri was going to do about it.
Yeah, well, we never know, do we?
I think most people might know by now that the choice really was states could elect to form their own health insurance exchange. And really what that is just a marketplace. I would say it's kind of like Expedia for travel, you know, an online place where individuals and small businesses could go, folks for whom health insurance has been a financial barrier, and really, you know, use the power of the marketplace, if you will, to help drive value and help drive down costs.
So they go there to find the best deal.
They go there to find the best deal for them. And there are a lot of rules around insurance companies participating in the health insurance exchanges. One of my favorite ones is that they're required to use plain language in their materials.
Amazing.
Amazing. And they have to give examples on the website of apples to apples comparisons on how they pay for things such as childbirth or such as cancer treatment. So really being more patient-centered or consumer-centered around information sharing. You know, I went around one time and asked people at work, you know, we're in healthcare, and asked them, do you know exactly what's in your health insurance coverage? And you know, it's complicated. Most people couldn't tell you exactly what's covered and what's not covered and what their obligations are. And
until they need it, they don't think about it.
And so there are rules to make it more clear so that people can make informed decisions. And in the law said states can choose to do it themselves and have ownership over that process. But if they choose not to, the federal government would do it. And then they came back and said, well, we can also do a hybrid where we have a partly federal, partly state-run health insurance exchange. I really always felt like we should do it ourselves because, you know, I think we know more about our insurance marketplace than the federal government does. And I think we know more about our communities and our healthcare providers. I just believe in local control over healthcare. I think when you get big monolithic programs, sometimes they work pretty well, but sometimes they don't work as well because you don't know really what's going on. You know, Medicare early on learned that lesson and started putting local people in charge of certain things. And so, you know, I really think that Missouri should have its own health insurance exchange.
Do you think that's still a possibility in Missouri?
I'm really not in a position to comment on that, but the Department of Insurance or might be in a better place, or maybe the leaders in the state assembly might be in a better place to comment on that.
Well, maybe we'll bring them on next time.
I think that would be a good idea. Because if you care about things like state control, if you really don't want the federal government involved in health care, it seems like you would elect to do your own health insurance exchange.
Yeah,
to
makes
me,
sense.
But you know, maybe I'm missing something.
Maybe we all are. Well, what else? What do you see 10 years down the road? What will our healthcare system look like compared to now?
Well, I hope it'll look very, very different. I hope that it won't be so fragmented, where patients go to different cities and different providers and spend all their time with specialists. And it's kind of ironic because I'm a specialist, but we really need people to have patient-centered healthcare homes where we have teams of healthcare providers that help manage that care. You know, we need to move away from a sick care model to a healthcare model. I always say we don't have a healthcare system, we have a sick care system, right? So we really need to move to a place where we're working with people and taking care of their health prevention needs and working with them on lifestyle and what motivates them to make healthy choices in their food choices and in their exercise and in their, you know, substance abuse. And we really need to work with patients. We need to become partners with patients. And patients need to take some ownership of their health care too. And I think you're starting to see that. You know, in the health reform law, there was a provision that allowed employers to have up to 30% of their tax bill for health insurance kind of relieved if they had wellness programs, that they could not charge their employees 30% less for health insurance if they participated in a wellness program.
That's pretty amazing discount.
And, yeah, and you're seeing those spring up all over the country. So employers...
Is that what you're describing, kind of the Kaiser Permanente model? It's kind of a holistic...
Kaiser's been in the forefront. There have been a lot of organizations around the country that have really been in the forefront of pushing really health care and wellness, not just sick care.
Right.
You know, we talk about different models. You know, the Mayo Clinic model is an interesting one because when you go there, they don't say, well, you need to see this specialist, so come back next month.
Right.
They might say, come back tomorrow, but they might say, you can see that person this afternoon. You know, it's about really meeting everybody's needs right when they need it. All in the same place.
Yeah. I actually had some personal experience with that. My father had a problem when we went to Rochester and without actually an appointment, we were there a week, but we saw at least half a dozen doctors of different specialties that really treated the whole person.
Exactly. And I think that's where healthcare is going, more to that holistic care, more to using a team, not just relying so heavily on doctors, but I think our nurse practitioners and our physician assistants and our pharmacists and our therapists and everybody, our nurses, and I think everybody in healthcare is going to have to practice to what we call the top of their license, so that I'm not taking care of acne and warts. You know, our nurse practitioner does most of that in our clinic.
Sure.
You know, so that my expertise is really focused on what it's needed for, which are the more complex patients. But we are in our own department really trying to push the boundaries. We're getting ready to start what we call store and forward teledermatology, where you can send us a photo and we'll say we need to see you today, or we can see you next week, or try this and let me know. So really using technology so that people don't have to take off work, sit in our waiting room, wait for us. We think that model is not patient-centered. We think it's yesterday. We want to be about tomorrow.
Amen. The med center, or the med school, I should say, is doing some experimenting, doing some different kind of curriculum. Are they preparing, you think?
Absolutely. We have a wonderful medical school, and our students are, you know, some of the best in the nation, actually, on tests across the nation. I mean, it's just a fabulous curriculum. Our health center, too, has won awards for being wired, being connected with health information technology. I think the exchange of health information is going to really change healthcare, so that people don't repeat labs and repeat x-rays and not know what happened to you. And so you don't have to fill out a form every time you go to the doctor's office. So all that information will be in there.
A central place.
Yes, and Missouri has opted for an opt-in system for Missouri's Health Information Network. It's called the Missouri Health Connection. That's also part of the some of the stimulus funds that came down in 2009. So that's really getting going now. And I think in the next few years, you're going to see a lot of excitement around sharing, with patients' permission, sharing their health information between providers so that we can coordinate that care better.
Lots going on.
Yes.
And you know what? We're out of time.
Okay. Thank you. It was really fun.
Thank you. And I hope that our viewers got something they could use out of this. I think they did. Very interesting. Thank you for being with us, Karen.
It was my pleasure.
And thank you for joining us. The League of Women Voters presents. And good night.